Hello, I'm Dr. Ari Kramer, and I'm a dedicated vascular access surgeon and chair of the Vascular Access Program at Spartanburg Medical Centre. I'm also the principal investigator of the FlexFirst AV Registry. I think the greatest unmet need in dialysis access care is durability. Fistulas and grafts are the preferred methods of access, but they often fail to provide meaningful outcomes due to neointimal hyperplasia and fibrotic remodeling. And these lesions become resistant to dilation, requiring high pressure angioplasty that increases the risk of rupture and early restenosis. And despite this, our current standard is still to go directly to balloon angioplasty. And when that fails, we escalate to a stent graft or drug-coated therapies. The problem, we believe, isn't that our destination therapies are ineffective. It's that they're often delivered to a vessel that isn't ready. In coronary, femoral popliteal, and below knee intervention, we've learned this lesson clearly. Vessel preparation is essential. The goal is to optimize compliance, reduce trauma, and improve the effectiveness of whatever follows. In the AV access space, however, we've overlooked that first step. In part, that helps explain traditionally poor outcomes associated with angioplasty alone. And even the major drug-coated balloon trials like Impact AV and Lutonix AV reinforce this concept, and they showed that destination therapy is only as effective as the prep that precedes it. Poor prep leads to poor drug uptake and poor long-term patency. That's why the FlexFirst AV registry matters. It's not a trial about balloon angioplasty. It's a trial about giving angioplasty and every therapy that follows a better foundation. The Flex Vessel Prep System is a dedicated mechanical tool that's designed to prepare the vessel before balloon angioplasty, and it does so in a controlled, reproducible, and I think an elegant way. At its core is a concept called kinetic endovascular microincision creation, or KEMIC, K-E-M-I-C. The catheter includes 3 radially opposed flexible struts, and each is tipped with a microsurgical blade that's about 1/1000th of an inch tall, or about 250 microns. And when deployed, the device presses gently against the vessel wall and is pulled back, creating 3 parallel longitudinal microincisions along the lesion. These incisions release circumferential wall tension, increase compliance, and allow the vessel to expand more easily with the balloon and at a lower inflation pressure. The Flex system doesn't ablate, excise, or leave behind any implant. It doesn't require any other energy. It's fully mechanical and integrates into the standard workflow with an 014 or an 018 guide wire and 6 French sheaths. Does one thing, and it makes the lesion easier to treat, and that's why it works. The FlexFirst AV registry was a prospective, multi-center observational study conducted at 4 U.S. clinical sites between 2022 and 24. A total of 130 patients were enrolled and all had symptomatic access dysfunction and were treated with Flex, followed by plain balloon angioplasty, no drug-coated balloons, and no pre-implanted stents. The patient population was intentionally diverse and high risk. 60% were Black or identified as African American, 37% were women, and 27% had cephalic arch lesions. Over 97% had previous interventions, with an average of 4.2 per patient. This was not a tightly controlled trial cohort. These were real-world patients with challenging anatomy, recurrence, and prior failures. The results were strong across the board. First, safety. There were no serious adverse events involving the access circuit at 30 days. Only one minor dissection required bailout stenting, which is 0.08% of the population studied, and that was a result of balloon angioplasty, not the Flex device. Efficacy at 6 months showed a target lesion primary patency of 70.7% overall, 75.6% in fistulas, 76.3% in cephalic arch lesions, and 55.2% in grafts. Circuit level patency was 54.3%, and clinical success, which was resumption of dialysis, was in 99.2% of patients. Technically, Flex was reliable. The mean number of passes was 4.8, and the average effacement pressure was just 10 atmospheres of pressure, much lower than what is typically needed for resistant lesions. And importantly, all of this was achieved using plain balloon angioplasty alone. There's no drug and no implant, and that tells us how powerful the preparation effect really is. I think there are really three takeaway messages that are key. And the first is we need to separate vessel preparation from destination therapy in our thinking, just as we do in coronary and peripheral vascular care. Secondly, Flex gives us a safe, simple, and effective way to implement vessel prep, especially in lesions that have failed angioplasty before. And third, we now have real-world evidence that preparation improves patency, it reduces complications, and may even extend the usable life of the access circuit, particularly in high-failure zones like the cephalic arch or a swing segment. It's not about replacing angioplasty, it's about giving angioplasties a better environment in which to succeed. I think the next step's already in motion. We're completing a 12-month follow-up, which will provide insight into longer-term durability. Future directions include comparative studies, Flex versus drug-coated balloons or stent grafts, perhaps combination therapy of Flex used as a prep step before drug delivery, and healthcare economic analyses, especially in outpatient and ambulatory surgery settings, subgroup exploration, which lesions and patient types benefit most. And ultimately, we believe Flex can evolve into a foundational tool, one that supports both basic and advanced access therapies, improving the initial mechanical conditions of the vessel. So the Flex First AV registry shows us that preparation is not just a technical step, it's a clinical imperative. And when we treat a vessel that is prepared, we reduce the pressure, reduce the risk, and often reduce the need for more complex therapy. This is how we improve outcomes, and this is how we preserve access. Flex doesn't change the endpoint, but it just makes us more likely to reach it. Thank you.